Welcome to the deep dive. Today, we're digging into something pretty significant, a persistent threat that, well, it affects our food, our economies, and even our health. Bovine tuberculosis, or BTB. So maybe let's start right there. What is bovine tuberculosis? Basically, it's a chronic infectious disease caused by a bacterium, Mycobacterium bovis.
That's it. And while cattle are the main ones, it actually hits a whole range of mammals,
Including humans, critically.
including humans, yeah. And it's often elusive, kind of hidden until the damage is already happening.
Right, which leads to why it's such a persistent global problem.
Exactly. It's got this sort of dual nature, huge economic costs for livestock folks, productivity losses, control programs, and maybe the biggest hit, trade restrictions. But then there's the public health side. It's zoonotic, meaning it jumps from animals to people. And what makes it really tricky is that silent aspect. Infected animals can look perfectly healthy for years, just spreading it quietly.
So our mission today is really to unpack all of that using the sources you've brought. We want to understand how this silent spread works, why an animal disease costs us so much, both economically and in human health terms.
Yeah, and how the global fight against it actually teaches us a lot about balancing these different pressures, economics, health, even ecology.
Okay, let's get into the cause then. The bacterium itself, Mycobacterium bovis. You mentioned it's related to the one causing human TB.
That's right, they're in the same family, the Mycobacterium tuberculosis complex. And M. bovis is incredibly resilient.
How so? What makes it so tough?
Well, it has this really unique cell wall. It's very rich in lipids, fats basically, contains something called mycolic acid. Think of it like a waxy armor plating.
Okay.
That waxiness makes it resist common lab stains. You need special acid-fast techniques just to see it under a microscope. But more importantly, it helps it survive the host's immune attacks.
So it can hide inside the very cells meant to destroy it.
Exactly. It can live and even multiply inside immune cells like macrophages. We call it a facultative intracellular pathogen. It's sneaky.
Yeah.
And because it's such a big deal globally, it's officially a notifiable disease, according to WHO, the World Organization for Animal Health.
So if it's that resilient, how does it actually move from one animal to another, especially in cattle?
The main way, especially with cattle bunched together, is respiratory, through the air.
Like coughing and sneezing.
Yeah, aerosolized droplets from coughing, even just breathing, especially in, high-density places like barns or feedlots.
Yeah.
That's prime spreading territory.
Are there other ways it spreads?
Oh, definitely. Ingestion is another key route. Calves are particularly vulnerable if they drink unpasteurized milk or colostrum from an infected mother.
Oh, okay.
And contaminated feed and water sources if an infected animal sheds bacteria there. This really brings us back to that silent spreader problem. Animals look fine, but they're shedding viable bacteria for potentially years.
So just looking for sick animals is basically useless for catching it early?
Pretty much, yeah. Clinical surveillance alone just doesn't cut it.
So, okay, the bacteria gets inhaled. What happens next inside the animal's body? How does the immune system react?
Right, so after inhalation, it usually gets picked up by macrophages in the lungs. These are immune cells. And this kicks off a really complex immune response.
And that leads to...
That often leads to the classic lesion of TB, the granuloma, something's called a tubercle.
Granuloma, is that the body successfully fighting it off, or is it more complicated?
It is complicated. That's a great way to put it. The granuloma is basically this organized ball of immune cells that walls off the bacteria. It tries to contain them, stop them spreading everywhere.
Okay.
In cattle, the center of these granulomas often gets this cheese-like look that's called caseous necrosis. Sometimes it even calcifies later on, gets gritty.
So it contains it, but doesn't necessarily kill it.
Exactly. It's a success in terms of containment, but it's also a failure to completely clear the infection. So M. bovis can just hang out in there, dormant sometimes, for years. It establishes this chronic, often latent infection, hiding in plain sight, essentially.
Which explains why symptoms are so rare, right? Most infected cattle just seem fine.
The vast majority are asymptomatic, yes. When you do see signs, it means the disease is pretty advanced. Things like progressive weight loss, being lethargic, lower milk production, maybe a chronic cough if the lungs are badly affected, and large lymph nodes you might feel or see internally.
Okay, so it's not just about sick cows. This thing has ripples way beyond the farm gate. Let's talk about the economic hit. The direct costs seem obvious enough.
Yeah, reduced productivity, less milk, slower weight gain, fertility problems, and then parts of the carcass or organs getting condemned at the slaughterhouse. That's a direct loss right there.
But the indirect costs sound like they might be even bigger.
They often are. Think about the cost of running these massive control and eradication programs. In England, for example, it's over $100 million a year.
Wow.
And a single outbreak, like one in Minnesota a while back, cost something like $60 million to deal with. But here's the thing, even though these programs are expensive,
They pay off.
they're highly cost-effective, actually. The U.S. program, for instance, is estimated to provide a net benefit of almost $160 million per year just by preventing those production losses and public health costs. It's a smart investment, ultimately.
Okay, but here's something that really stood out from the sources. The biggest economic driver for getting rid of BTB isn't even animal health directly, it's trade.
Absolutely. International trade is huge. Many countries will only import live cattle or meat or dairy from regions that are officially certified as TB-free by WOAH.
So if a country has an outbreak and loses that status,
Boom. Immediate, severe trade restrictions. We're talking potentially billions in lost export revenue. That puts immense pressure on countries to maintain or achieve TB-free status. It's a massive economic lever.
Right. And that brings us to the other major impact. Public health. Zoonotic TBM bovis in people.
Yeah, and clinically, you can't tell it apart from regular human TB caused by M. tuberculosis just by looking at the patient or their symptoms.
Yeah.
You need specific lab tests to know the difference.
And historically, this was a much bigger problem, wasn't it, before we understood it well?
Oh, massively. Before the 20th century, particularly with unpasteurized milk being so common, zoonotic TB was a major killer, especially for kids. One estimate suggests maybe 15% of all human TB cases back in 1900 were actually caused by M. bovis from contaminated dairy.
15%. That's staggering. It really highlights how linked our food and health were.
It really does. But then came something incredibly simple, yet revolutionary: pasteurization.
Just heating the milk.
Just heating the milk. It acted as this critical firewall. Widespread pasteurization in developed countries absolutely decimated the rates of zoonotic TB. It basically broke the link between BTB levels in cattle and TB levels in people. A huge public health win.
But it's not completely gone, right? The risk is still there, globally.
Definitely still a threat. The WHO estimated, I think it was in 2016, around 147,000 new human cases and maybe 12,500 deaths globally from zoonotic TB.
Wow. Where are those cases concentrated?
Mostly in low- and middle-income countries, places where pasteurization isn't consistently practiced and where people often live in very close contact with their livestock.
And in developed countries today, is it still a risk?
The risk to the general public is very low, thanks largely to pasteurization and control programs. But it remains an occupational hazard. Farmers, vets, slaughterhouse workers, anyone with direct contact with potentially infected animals or tissues is at higher risk.
And there's a treatment complication too, isn't there? Something about drug resistance.
Yes, this is really important clinically. M. bovis is naturally or intrinsically resistant to pyrazinamide. That's one of the standard first-line drugs we use to treat human TB.
So if doctors don't know it's M. bovis,
they might prescribe a standard treatment regimen that includes pyrazinamide, which won't work against M. bovis. The patient gets inadequate treatment, which risks treatment failure and potentially the development of resistance to other TB drugs. So identifying the specific bacterium is crucial.
And it can even go the other way. Humans giving it back to cattle.
Yeah, reverse zoonosis.
Okay.
It's considered less common, but epidemiological studies have definitely shown it happens. Infected people can, in some circumstances, transmit M. bovis back to cattle herds. It's a two-way street.
Okay, so diagnosing this hidden disease is obviously key. If you can't rely on seeing sick animals, how do you find it?
You have to rely on tests that detect the immune response or the bacteria itself in the lab, not just visual signs.
And the classic test is the skin test, right? The TST.
Exactly, the tuberculin skin test, or TST. It's been the cornerstone for over 100 years. The basic idea is it detects a delayed type hypersensitivity reaction, meaning you inject a little bit of purified protein from M. bovis, called PPD, under the skin. If the animal's immune system has seen M. bovis before and is sensitized, it will react to that PPD, causing localized swelling at the injection site after a couple of days.
How is that actually done on the farm?
There are a couple of main procedures. Often the first step is the caudal fold tuberculin, the CFT. That's usually done in the fold of skin under the tail. It's a screening test.
And if that shows a reaction?
Then they're usually retested using the comparative cervical tuberculin, or CCT. This one's more specific. It involves 2 injections in the neck, one with bovine PTD, like before, and another with avian PPD, from a related but usually harmless environmental mycobacterium.
Why 2 injections?
By comparing the size of the swelling of the two sites, vets can better tell if the reaction is truly specific to M. bovis or just a cross-reaction to those other environmental bugs. It helps rule out false positives from the screening test.
Let's talk about how well these tests work. The TST is known for being very specific.
Extremely specific, around 99.98%. That means very, very few false positives. Only about 1 in 5,000 uninfected animals would react. And that high specificity is absolutely vital for large-scale testing programs. You don't want to be culling thousands of healthy animals unnecessarily.
But the downside is sensitivity.
Right. Its sensitivity is only moderate, maybe around 81%. So it can miss infected animals maybe up to 1 in 5. Especially animals very early in infection or those really sick ones whose immune systems aren't responding properly anymore, a state called anergy.
Missing 1 in 5.
Yeah.
That sounds like a big gap if you're trying to eradicate a disease.
It is, and that's where the other main test comes in. The blood test, the interferon gamma release assay, or IGRA, often just called the gamma test.
How does that one work?
It's done in the lab in vitro. You take a blood sample and you stimulate the animal's T lymphocyte-specific white blood cells with M. bovis proteins. If the cells have been primed by a real infection, they'll release a signaling molecule called interferon gamma, or IFN, which you can measure.
And how does its performance compare to the skin test?
Generally, it's more sensitive, maybe around 90% sensitivity, so it catches more infected animals, and often earlier than the skin test can.
Better sensitivity sounds good. What's the catch?
The catch is lower specificity, maybe around 96.6%. So you get more false positives with the IGRA, maybe 3 or 4 uninfected animals reacting out of every 100 tested.
Okay, so now we have this dilemma. TST, super specific, misses some cases. IGRA, more sensitive, catches more, but flags more healthy animals too. How do programs actually use these two tests together?
They use a smart two-tiered strategy, basically. For broad, routine screening of many herds, the TST's high specificity is king. It's cost-effective and avoids unnecessary culling on a mass scale.
Right.
But if you have a confirmed outbreak in a herd, then the priority shifts. You need to find every single infected animal to stamp it out. That's when the IGRA's higher sensitivity becomes really valuable. You use it strategically, often alongside the TST, to maximize detection, even if you accept a slightly higher false positive rate in that specific high-risk situation.
It's about using the right tool for the specific job at hand.
Exactly. Balancing efficiency with thoroughness.
What about confirming the diagnosis definitively, beyond these live animal tests?
Definitive diagnosis relies on finding the bacteria or the damage it causes after death. So, post-mortem examination and lab confirmation.
Post-mortem, like at the slaughterhouse.
Yes, routine inspection of carcasses at slaughter is actually a cornerstone of surveillance in many programs, like in the U.S. Trained vets look for the characteristic lesions.
What do those lesions actually look like?
We call it gross pathology, which
Yeah.
you can see with the naked eye. The classic sign is the tubercle. These are nodules, often yellowish-white, encapsulated. If you cut them open, they can have that cheese-like caseous texture, or they might be gritty calcified.
And where do they usually find them?
Most often in the lymph nodes, especially around the head and the chest and in the lungs themselves. Makes sense for a respiratory infection, right?
Yeah, absolutely. And then in the lab, how do they confirm it's really M. bovis?
The absolute gold standard is microbiological culture, growing the actual bacteria from a tissue sample.
But that takes time, doesn't it?
A long time. M. bovis grows incredibly slowly. We're talking 8 weeks, maybe even longer, to get a positive culture result. That's often too slow for rapid response during an outbreak.
So what's faster?
PCR, polymerase chain reaction. This is a molecular test that detects the bacteria's DNA directly from the tissue sample. It's highly sensitive and much, much faster. You can get a result in hours instead of weeks.
So putting it all together, the diagnostics work in synergy.
Beautifully, yes. Slaughter surveillance is like casting a wide, passive net, hoping to catch those rare needle and haystack cases. When it finds one, that triggers the active targeted response, using the live animal tests, TST and IGRA, to go into the herd of origin, trace contacts, and eliminate the infection. It's a layered defense.
Let's shift to the big picture. National eradication programs. The U.S. program, started way back in 1917, is often held up as a success story, right?
A remarkable success, yeah. They took prevalence down from maybe 5% of cattle herds back then to less than 0.001% today. It shows what sustained, science-based effort can achieve.
What's the core philosophy behind a program like that?
It's fundamentally based on test and slaughter. Or maybe more accurately, test and remove. You identify infected animals through testing, and then they're humanely removed from the population.
No treatment.
No treatment for cattle, generally. There are concerns about creating carrier animals that might still shed bacteria, plus the public health risk and the potential for drug resistance. So removal is the strategy.
What are the key components of these programs?
You need strong surveillance, like that slaughter inspection we talked about. Crucially, you need traceability, being able to track an infected animal back to its original herd. Then, systematic herd testing when infection is suspected or found, quarantining the herd using TST and sometimes IGRA, and strict controls on moving animals between areas with different TB statuses.
And if a whole herd is found to be infected,
The primary approach in many programs, especially for heavily infected herds, is depopulation, humanely euthanizing the entire herd to eliminate the source of infection quickly. Sometimes, particularly if infection levels are low, a test and remove approach is used, repeatedly testing and removing only the reactors over time. But depopulation is often seen as more effective for complete eradication.
that sounds drastic, but I guess necessary in some cases. But it's not all down to government programs, is it? What can farmers themselves do? Biosecurity must be huge.
Absolutely critical. Producers are the front line of defense. One of the best things is maintaining a closed herd, if possible, raising your own replacement heifers instead of buying them in.
And if they do need to buy animals,
Source them only from herds certified as TB-free. And even then, implement a strict test, isolate, retest protocol. Keep new animals separate for at least 60 days, test them before they mingle with the main herd. It's like a quarantine period.
what about protecting the farm environment?
Good fences are key. Double fencing along boundaries prevents nose-to-nose contact with neighboring cattle. Strict biosecurity for visitors, vehicles, equipment, anything that could carry the bacteria onto the farm, what we call fomite transmission.
And wildlife. We haven't talked much about that yet.
A huge issue in some areas. If BTB is established in local wildlife, you need wildlife-proof fencing around feed storage and maybe even pastures, if feasible. Secure water sources. Basically, minimize any chance for livestock and wildlife to interact or share resources.
Okay. And one more for the calves.
Definitely feed pasteurized colostrum and milk. It's simple, but it breaks that potential milk-borne transmission route, not just for BTB, but other diseases too. A really vital practice.
So despite all these efforts, eradication still faces major hurdles globally. You mentioned wildlife is at the biggest sticking point now, especially in developed countries.
In many developed countries that have largely controlled BTB in cattle, yes, wildlife reservoirs are arguably the single biggest barrier to final eradication. M. bovis can establish itself and circulate within certain wildlife populations, creating a persistent source of infection that can spill back into livestock.
What kind of animals are we talking about?
It varies geographically. In parts of North America, it's white-tailed deer. In the UK and Ireland, the European badger is a major maintenance host. African buffalo in southern Africa, brush-tailed possums down in New Zealand, wild boar in Spain and Portugal. The list goes on.
So it stops being just an agricultural problem and becomes an ecological one.
Exactly, and often a very politically and socially charged one. Managing wildlife diseases is complex and often controversial. It's truly the last-mile challenge for eradication in many places.
And we still have limitations with our tools, right? The tests aren't perfect.
No diagnostic test is 100% sensitive and 100% specific. That inherent imperfection means you might miss cases, or you might remove healthy animals. It's a constant balancing act. And effective vaccines for cattle, still largely elusive. The main one available, BCG, which is used in humans, can unfortunately interfere with the TST skin test, making it hard to tell vaccinated animals from infected ones. That complicates its use in control programs.
And the picture is quite different in developing nations.
Starkly different, often. While developed countries are wrestling with wildlife and fine-tuning diagnostics, many developing countries face much more fundamental challenges. Lack of financial resources for robust surveillance, for compensating farmers for culled animals, insufficient veterinary services, and lab capacity.
And social factors.
Sociocultural practices, like the regular consumption of raw, unpasteurized milk or undercooked meat, can keep the transmission cycle going strong between animals and humans. It often creates this vicious cycle. High disease burden in cattle leads to significant human health problems, but the limited resources available often get pulled towards treating people, leaving fewer resources to tackle the animal source of the infection. It's incredibly challenging.
So wrapping this all up, bovine tuberculosis is clearly this complex chronic disease, big economic weight, serious potential for human illness. But we've also seen that controlling it, even getting close to eradicating it in livestock, is possible.
Definitely possible with sustained science-driven strategies like test and slaughter, good surveillance, biosecurity. It works. But the global picture is really polarized now.
Developed countries stuck on that last mile with wildlife.
While developing nations are still tackling the foundational infrastructure and resource challenges, it really screams for a One Health approach, doesn't it?
Absolutely. Integrating animal health, human health, and the environment, the ecology.
You can't solve BTB by just looking at one piece. Veterinary medicine, public health, wildlife biology, they all have to work together.
Which brings us to a final thought for you, the listener. We talked about pasteurization, a relatively simple intervention with massive public health benefits historically. Now we see the need for these complex, interconnected One Health strategies for diseases like BTB. So thinking ahead, what might be the next silent public health triumph we need to focus on? Something that requires collective action, even if its benefits aren't immediately obvious day to day. Something to ponder. We hope this deep dive gave you a much clearer picture of BTB's many facets.